usage. His bowel, bladder, and sleep pattern were normal. No history of alcohol consumption. No significant family history or any treatment history in the past. To summarize, my patient is a 51-year-old gentleman who is a BD smoker, presented with painless progressive hoarseness of voice for past 4 months with no other symptoms. Shall I proceed to examination, sir?
So, if you're looking at if you look at a patient with hoarseness,
Yes, sir.
and how would you say that this hoarseness is a malignant process or a benign process?
Sir, if it is of short duration and with progressively increasing.
So if you have chronic laryngitis or vocal nodule also, you can have the same problem.
Yes, sir. Yes, sir. No other contributory symptoms like fever or trauma.
Why are you asking for fever?
Any inflammatory or infective condition? Chronic.
No, the glottis is there's very less lymphatic drainage from the glottis. Usually a glottic pathology will not have systemic symptoms like fever. Why did you ask for fever? Is there any reason you asked for fever? I don't think it's relevant, but explain why you asked for fever.
Okay, sir. We thought some chronic pharyngitis or laryngitis.
But why would pharyngitis cause hoarseness of voice? Pharynx and larynx are different.
Yes, sir.
So usually, if you have a painless, progressive hoarseness,
yes, sir,
with no systemic complaints,
yes, sir,
and the hoarseness persists the whole of the day.
Yes, sir.
So if you have laryngitis or if you have any inflammatory process, usually the hoarseness will worsen towards the end of the day.
Yes, sir.
But if you have hoarseness from the morning till night, it probably means that there is a more definitive pathology than inflammation or infection. So, you just have to, don't bring in this fever because TB, laryngitis and all is a thing of the past. It is a thing of the past. Syphilitic laryngitis is a thing of the past. Granulomatous laryngitis is a thing of the past. But in this case, in this patient, with this progressive hoarseness of voice, which has been worsening for the last 2 months, what pathologies would you think?
It could be a benign vocal nodule, or it could be malignant early laryngeal cancer also.
Okay, so benign vocal nodule is usually associated with voice abuse. That is not there in this patient. So that is out of the question. So malignancies, what are the things that you can suspect in this patient?
It could probably be a early glottic cancer.
Yeah.
Or any thyroid cancer with recurrent laryngeal nerve palsy.
Okay, so it is either intralaryngeal or extralaryngeal. You're right. Yes. So intralaryngeal is confined within the confines of the thyroid cartilage. So the hoarseness we have to break down a little bit more. So you can have change of voice from glottic cancers. You can have change of voice from supraglottic cancers. You can have change of voice from oropharyngeal cancers. And you can have change of voice by nerve involvement from thyroid cancer. So you have to say like that in the exam. So hoarseness can be defined as different qualities of voice change. Each is different. So we can have intralaryngeal or extralaryngeal pathologies. See, recurrent laryngeal nerve will not cause hoarseness. It will cause a breathy voice or stridor, correct?
Yes, sir. Yes, sir.
Hoarseness is different from breathy voice. Supraglottic and oropharyngeal cancers will cause muffled voice, hot potato voice or muffled voice.
Okay, sir.
So you have to say that when I consider this patient, you should not say hoarseness. You should say change in voice.
Change in voice.
What is description of hoarseness of voice?
It's a rough voice with.
How do you know his voice before?
It is by his words.
So don't use hoarseness. Say change in voice. That's it.
Yes, yes.
Say change in voice. Don't commit to hoarseness or supraglottic voice or oropharyngeal voice or say change in voice. That will keep you safe when giving the DD for a lot of things.
Yes, sir.
Do you think a recurrent laryngeal nerve patient who is well compensated will have hoarseness of voice?
No, sir.
Yeah. So in the exam, just use change of voice. That is the safest thing that you can say.
Okay, sir.
Okay, very good. So your history shows a farmer who is 50 something with change in voice for 4 months, worsening over the last 2 months, who has a history of tobacco smoking, who doesn't have any associated complaints or systemic complaints. And your suspicion is that you want to evaluate him for a laryngeal pathology. That's all.
Yes, sir.
You want to evaluate him for a laryngeal pathology.
Yes,
okay, go to your examination.
General examination, patient is conscious, comfortable, cooperative, well-oriented to time, place, and person, moderately built and nourished. His ECOG scale is 1, and vitals stable, and no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy. Skull.
Again, I told you the other day, be careful of clubbing. Don't, it's a MBBS question, but don't, unless you examine and all that, don't use that word clubbing because most of these patients will have clubbing. Don't get caught in that. Examine and be clear that the angle and the striae, all those things. You read about clubbing a little bit because some examiners might catch you there and then hold you there. It's not for MCH level or DNB level, but don't commit on this. Clubbing is something that I feel very awkward when somebody says that they have such a long smoking history and they don't have clubbing. Anyway, proceed.
Local examination on inspection, neck extension is normal. Larynx.
Okay. Why did you ask for neck extension?
In case of advanced laryngeal malignancy with prevertebral fascia involvement, so
you think prevertebral fascia involvement prevents neck extension? Where is it given like that? What are the muscles involved in neck movement? You think prevertebral muscles are responsible for neck extension? No, sir, but prevertebral fascia involvement can cause restriction of. So just say neck movements are normal. No, prevertebral involvement doesn't prevent neck extension. Just say neck movements are normal. That's all. Okay, sir. If they ask you why neck movements did you examine, you say you want to see if there's any extra laryngeal extension of the tumor. That's it. Don't commit anything deep and get caught. You understand? Yes, sir. If they ask you why are you seeing for neck movement, I want to rule out extra laryngeal extension. That's all. Okay, sir. Okay. Prevertebral involvement limits neck movement, but it doesn't prevent extension or anything like that. Prevertebral muscles are not responsible for neck extension. So just say neck movements are normal. Yeah. Okay. Okay. Trachea and larynx appear to be in midline. No, trachea is in midline. Larynx, there's nothing about larynx being in midline or not. You said, yeah, carry on. Don't say larynx is in midline. There is no meaning of that. Larynx is always in the midline. Trachea, laryngeal extensions can present as swellings or bulge or whatever, but trachea is what is important. Okay. Why is this trachea position important? So there's a dictum where the larynx goes, the trachea follows. Okay. There is a dictum like that. So you have a malignancy or a pathology that moves the larynx, the trachea also will move along with it. So that was Jackson's principle. Where the larynx goes, the trachea follows. Okay. So your neck examination on inspection didn't show any limitation of neck movement. Very good. larynx was okay, trachea was okay. Yeah, very good. Yeah, go ahead.
No laryngeal widening. Skin.
Very good. How do you measure laryngeal widening on inspection?
Sir, just by inspecting,
some well-built people will have a wide larynx. Women will have a narrow larynx. How do you explain that? Women have a narrower larynx than men. No, how do you explain that?
I am not sure.
If you have a well-built person, his larynx will appear wide compared to a thin person.
Okay, sir.
So laryngeal widening. Tell me how you explain that.
I'm not sure, sir.
So if you inspect a fullness in the region of the larynx, there is laryngeal widening.
Okay, sir.
Normally, is the larynx visible on inspection, except for the laryngeal prominence?
No, sir.
So when you have laryngeal widening because of an intralaryngeal pathology, there will be obvious widening.
Okay, sir.
So in normal people, you don't see the lateral lamina, you don't see anything except for the laryngeal prominence.
Yes, sir.
So you have to tell the examiner, in cases of extensive interlaryngeal tumor, yes, the larynx will be widened so that you're not able to see the difference between the larynx and the sternocleidomastoid muscle.
Okay, sir.
It will not be well defined.
Okay, sir.
So if they ask you how is it's ill-defined enlargement of the thyroid cartilage with prominence of the cartilage, that's all. Very good. Go ahead.
Neck skin oral was normal. Oral cavity was normal. There is no obvious neck swellings. No other obvious neck swelling.
Very good. What other things? Okay, you said no obvious neck swellings. Okay, very good. Yeah.
On palpation, no widening of the laryngeal framework present.
Okay, how do you, on palpation, how do you ascertain widening of the laryngeal cartilage?
Say whether the laryngeal framework is intact or not, or any.
No, that is, if there's extra laryngeal spread, it won't be intact. You will feel a deficiency in the cartilage as you palpate. But how do you define laryngeal enlargement on palpation?
The irregularity or any growth palpable on the lateral lamina or.
So it's basically asymmetric.
Yes, sir.
Okay. If you have a lateralized tumor, you will have asymmetrical widening of the thyroid cartilage. If it is symmetric tumor, you will have bilateral enlargement. But again, it is in relation to the sternocleidomastoid and the carotid sheath. Okay, very good. So you didn't feel there was any, and when you palpate, you also have to palpate the thyroid membrane and the cricothyroid membrane. You have to palpate them for fullness and all those things.
Yes,
okay,
sir.
Very good. Go ahead.
Laryngeal crepitus present, sir.
So you know those two signs, no? What is the laryngeal crepitus sign called? What is Boy's sign and what is Jackson's sign?
Yes, sir. We are not very sure, sir.
Okay. So you said laryngeal crepitus was intact. Okay, very good. What does that signify?
Sir, the tumor has not spread into the prevertebral fascias.
So there is no Jiva. Remember, when we talk in the exam,
yes, sir,
you have to give broad answers so that you will extract more questions on your topic of your strength. Okay, so you should say, don't say post-cricoid, don't say prevertebral. Just say there is no posterior extension of the tumor. That's all.
Okay, sir. Okay, sir.
Then the next question will be, what do you mean by posterior extent of tumor?
Okay, sir.
Then your answer will be, there is no post-cricoid or prevertebral involvement.
Okay, sir.
Now you take time away from your other questions, no?
Yes, sir. Yes, sir.
You understand? So it should be like dialogue. No posterior extension of tumor, hence crepitus is intact. Very good. Okay, proceed.
And Hopkins examination. So this is the tumor, sir. The growth is present in the right true vocal cord in the anterior 1/3, just extending up to anterior commissure. And bilateral cords are mobile. There is no supraglottic extension, and rest of the subsides of larynx and pharynx are normal.
So what are the hidden sites of the larynx where this tumor can spread? On Hoppen's examination, you found that the tumor was in the vocal cord, correct?
Yes, sir.
So please read the anatomy of the true vocal cord, false vocal cord,
Yes,
ventricle and subglottis.
Yes, sir.
You have to read that.
Yes, sir.
You don't have the this thing, no? You guys don't have the Biller larynx textbook, no? That is given very well, but it will be too much for you for your exams. Okay. So now, what are the hidden areas of the larynx?
So
you told me that growth is at the right vocal cord anteriorly going to anterior commissure.
Yes, sir.
What is the importance of anterior commissure? What joins at the anterior commissure?
Broyles ligaments.
Excellent.
And there is no perichondrium or between.
Yes, correct. Very, very good. Okay. So that it is an area deficient of inner perichondrium, not outer perichondrium. Inner perichondrium.
Yes, sir.
So from the anterior commissure, where are the others? Or tell me the sites that this tumor can spread invisibly.
Sir, into tracheal cartilage and.
You mean subglottis, anterior subglottis.
Anterior subglottis.
It is called the anterior subglottic wedge.
Anterior subglottic.
Wedge.
Okay, sir.
WEDGE, wedge.
Yes, sir.
And then where else? What else is close to the anterior commissure? From above, what is close to the anterior commissure?
Sir, the ventricle or saccule of the larynx.
That is laterally. That is lateral and superior. Anteriorly, what is close?
Anteriorly, thyroid lamina, sir. Inner thyroid.
No, above, just above.
Epiglottis, sir.
Excellent. Where does the epiglottis attach there?
Between the fusion of thyroid lamina, sir.
Yeah. So you consolidate your answer. Where else can this tumor grow?
It can grow into the epiglottis or into the pre-epiglottic space.
No, pre-epiglottic space is higher. Okay, you keep it epiglottis. Epiglottis. Then I told you something.
Yes, sir. Anterior subglottic extension.
Anterior subglottic wedge, and where else?
Laterally into paraglottic space and ventricle of the larynx.
Excellent. So tell me the four again.
Sir, into the epiglottis superiorly and anteriorly into the anterior subglottic wedge.
Yes.
Laterally to the ventricle of the larynx and paraglottic space.
Okay. So if you have paraglottic space involvement, what is the finding?
Sir, the vocal cord will have impaired mobility, sir.
Excellent. So that is one very important thing.
Yes,
how do you assess subglottic extension?
Sir, subglottic extension.
With angled scope?
Yes, sir, with 70-degree angled scope.
Angled scope. How will you look at ventricular involvement?
It is also using the angle scope only, sir.
Okay, very good. Angle scope, or when you do a DL scoping, you can evaluate that. Okay, very good. What is the importance of ventricular involvement?
It means that supraglottis is also involved, sir.
Yes, so what do you call such tumors?
T2 tumors, sir.
No, ma'am. Something, some word, some glottic tumor, something. Transglottic tumors.
Okay, sir. Transglottic.
When the tumor is crossing the ventricle, it is a transglottic tumor that will upstage the tumor, correct?
Yes, sir. Yes, sir.
Okay, so in this patient, you found the tumor confined to the vocal cord going to anterior commissure. How would you like to evaluate this patient?
By doing a direct laryngoscopy and biopsy, sir, followed by.
So you want evaluation clinically and radiologically. So you answer, always give time for the examiner to ask another question which you know the answer.
Okay, sir.
So you say, I want to assess clinically and I want to assess radiologically.
Yes, sir.
Okay, clinically, how would you assess?
By doing a direct laryngoscopy, and
Excellent.
at the same time I can plan a biopsy of the lesion, sir.
Okay, excellent. Radiologically?
Radiologically, I would like to do CCT of neck and thorax, sir.
Okay. So
After
your CCT, do you have any specific requirements?
Thin cuts, sir. Thin cuts, 0.6 mm thin
Yeah,
cuts.
0.6, 1 mm. It has to be high resolution, contrast, and CT.
Yes, sir.
What will you look for in the CT? We'll go to endoscopy later. What will we look for in the CT?
So the site of the lesion and the extension of the lesion.
Right. Okay. So how would you make out on CT the site and extent of the lesion?
Whether the growth is horizontal or vertical dimensions, and also the space involvement, so the paraglottic space, and whether there is erosion of thyroid lamina.
Okay, let's split this answer. Okay. You said site of lesion. How do you assess site of lesion?
Whether it is glottic or
No. We know it's glottic. How do you say it is glottic on CT? Or how do you say it's pathology on CT?
There will be irregular.
Very good.
Irregular,
Say.
irregular thickening with altered density, sir.
No, density is an MRI finding, not a CT finding. So you will see an irregular,
Yes, sir.
asymmetrical,
Yes, sir.
contrast enhancing lesion on the free border of the vocal cord.
Okay, sir.
So that is the site. Okay,
sir.
And then when you scroll downwards in an axial section, you can see there is subglottic extension.
Yes, sir.
Correct? How are the spaces that are involved?
So the lateral extent of the lesion, sir.
No, how do you see it? There's the effacement of the fat, correct?
Yes, sir.
Paraglottic fat, pre-epiglottic fat, you will see the effacement of the fat. Yes. How do you describe cartilage erosion on CT scan? Because laryngeal cartilage ossifies at different ages and at different variations.
Yes, sir.
So how will you assess cartilage invasion on CT scan?
Sir, asymmetry and...
No, cartilage invasion. I'm not talking about soft tissue.
Okay, sir. Sir,
so which are the cartilages that are ossified? Which are the cartilages that are non-ossified usually at this age?
I'm not very sure, sir.
Okay. So you have to read that. Okay. So there are three cartilages that you have to read.
Yes, sir.
One is thyroid cartilage, one is arytenoid cartilage, and one is cricoid cartilage.
Okay, sir.
What are the CT scan findings of involvement of these three? You have to read.
Okay, sir.
Okay. So your CT showed right cord lesion going to the anterior commissure.
Yes, sir.
But there is no cartilage erosion of the anterior commissure.
Okay, sir.
There is no subglottic extension. There is no supraglottic extension. And you confirmed all this during TL scoping.
Yes, sir.
So what is your stage?
Sir, T1 N0.
Okay, T1 N0. Okay, so this is a stage 1 tumor.
Yes, sir.
And your biopsy came back as squamous cell carcinoma.
Okay, sir.
What will you plan for this patient? What are the treatment options available? And how will you decide what treatment you want to give to this patient? So in this whole case, nobody will care about history, nobody will care about findings. They will only ask you, how do you assess the extension of this tumor?
Okay, sir.
Both clinically and radiologically.
Yes, sir.
It's not wrong if you say you want to do MRI also. That is also not wrong, because MRI is earlier detection of cartilage involvement. But CT is absolutely fine, but you should know which cartilages ossify, what rates they ossify, and where sclerosis and where lysis is important. Sclerosis also is a sign of cartilage involvement.
Yes, sir.
Lysis also is a sign of cartilage. You have to read that.
Okay, sir.
And Why MRI in early stages is important for cartilage erosion also, you have to read. This will be the only question.
Okay, sir. Okay.
Radiological evaluation of a T1 is very, very important.
Okay, sir.
That's all they'll ask you with this whole thing. Nobody will ask you history or clinical finding. Nobody will ask.
Okay, sir.
Please read the radiological evaluation of larynx. There are many free papers you can download and you can read. Okay. Jiva, T1N0 larynx, patient came to you in clinic. How will you discuss or how will you plan your treatment?
Sir, I would like to offer them the option of transoral laser micro surgery.
Just before making your judgment.
Yes, sir. Sling.
No, ma. Any imaging, anything, NBI or anything. Do you want to do anything like that?
Yeah, NBI.
Do you want to do narrowband imaging or anything like that?
So narrowband imaging can be done, sir.
No, you should not say can be done. Narrowband imaging will help to assist us in determining the extent of the lesion. Jiva, നമ്മുടെ പേசுறതെല്ലാം we have to talk in a very polite way and a very documented way. Yes, narrowband imaging will help us assess the extent of the lesion. Yes, and field cancerization. So there are many classifications for NBI findings. You have to read that.
Yes, sir.
What is grade 1, grade 2, grade 3, grade 4? You have to read that. That makes a lot of difference in our management. So if they ask you if you are planning a non-radiotherapy approach, yes, what would you like to do to determine your approach? You have to say we will do narrowband imaging. Okay, ma. Okay. So tell me your logic for transoral laser microsurgery versus RT.
Sir, for if the lesion is involving the anterior commissure, yeah, then radiotherapy is slightly better than laser microsurgery.
That is not true. Evidence shows. Okay, tell me what is the failure, yes, in radiation in patients who have anterior commissure involvement?
Around 16%, sir.
No.
12%.
No. Absolutely not.
Okay, sir.
So, you have to read this also.
Okay, sir.
Success of midcord lesion.
Yes, sir.
For TLM.
Yes, sir.
Versus success of anterior commissure lesion with TLM.
Okay, sir.
Versus midcord lesion with radiation.
Yes, sir.
And anterior commissure involvement with radiation.
Okay, sir.
So that is not the logic.
Okay, sir.
So when will you define a patient is good for transoral laser microsurgery?
So if after assessing the exposure is good.
Excellent. Very good. So we have to have exposure. That is given by the laryngoscope. I hope you yes, must have read about laryngoscope. Okay. So the most important thing is exposure. Next thing is
extent of the disease.
Mapping of the disease.
Mapping of the disease.
You have to be very sure of the mapping of the disease. Okay.
Okay. Then
availability of follow-up.
Okay, sir.
Availability of follow-up. So, okay, if I have to tell you that this patient has to go for TLM, what you know the types of cordectomy?
Yes, sir.
European Laryngeal Society. You know that, right?
Yes, sir.
So you know how much you have to take the anterior commissure. All data that have been published so far says that if you have anterior commissure involvement, the results and laryngeal preservation rates are better with TLM than radiation. You have to remember that.
Okay.
I will send you today evening my presentation on all of this. Yes, you read that. It's an old presentation, but the data still holds. You have to read that.
Okay, sir. Okay, sir.
Okay. So tell me, so you said adequate mouth opening.
Yes, sir.
I mean adequate exposure, not mouth opening, adequate exposure as per laryngo score.
Yes.
Then you said mapping of the tumor.
Yes, sir.
And then you said adequate cordectomy.
Yes, sir.
Adequate cordectomy will be type 6 for anterior commissure and subglottic, whatever. We have to take the inner pericontum. It won't be anything less than that. So
Yes.
these are the three things.
Yes, sir.
Now, what is the advantage of transoral laser microsurgery for such tumors?
Sir, early recovery, single stage.
Excellent. So early recovery, single stage, yes. Then
voice quality is comparable, sir. And
no, the voice quality becomes worse as you go up the oral laser microsurgery. If you do a type 1, type 2, voice outcomes are equal, but not for type 6 or type 5. It's once you go through vocalis muscle and perichondrium, the voice outcomes are not good. So we remember very clearly all the studies that have been published so far have been comparing radiation with limited cordectomy.
Okay, sir. Okay, sir.
Grilich is the most recent article which said that voice handicap index is better in TLM. Okay, is there a difference in survival between radiation and TLM?
No, sir.
Very good.
No difference.
So you know all the systematic reviews, you have to read that. Very correct. Very, very correct. Is there a difference in voice quality?
Yes, sir.
No, there is no difference. If you are limited to a type 1, type 2 cordectomy and radiation, there's no difference.
Okay, sir.
So what is the problem with literature? Because the extent of TLM has not been matched with the radiation.
Okay, sir.
So extensive TLMs don't compare with the radiation.
Okay, sir.
Yeah. If you do a type 3, type 4, the voice is not going to be the same. Okay. First, you're absolutely right. No difference in overall survival. There's no difference in limited TLM versus radiation. There's no difference. What about laryngeal preservation rates?
Laryngeal preservation rates are better with TLM, sir.
Excellent. Why? Where did this paper come from?
I read and forgot, sir.
From Italy, from Piazza's group. It is from Italy, from Piazza's group. Excellent. Laryngeal preservation rates are better with TLM compared to radiation. Why?
Center.
So if you fail the first TLM,
yes, sir.
There's always options for a second TLM or a conservative laryngeal surgery, correct?
Yes, sir. Yes, sir.
But when you fail radiation, if you fail radiation for a T1 larynx, what is the salvage options that you have?
So theoretically, even though we have the option of partial laryngectomies, but
Yes.
most likely it will end up in total laryngectomies.
Very good. So what partial laryngectomies can you offer a patient who has failed radiation for T1?
That is a supracricoid laryngectomy.
Excellent. Why supracricoid? Why not any other horizontal or vertical partial laryngectomy?
So there will be extensive fibrosis and edema that limits.
No. So the cartilage is already radiated. So if you try doing anything with the cartilage, there can be chances of necrosis and other problems. Yeah?
Yes.
Okay, very good. So you tell your patient who has a T1, you have comparable overall survival. Yes, you have better laryngectomy free survival, correct?
Okay, sir. Yes, sir.
And we can preserve voice.
Yes, sir.
Based on type 1, type 2 cordectomy, we can preserve voice.
Yes, sir.
When will you suggest radiation?
So if it is a bulky tumor crossing over the opposite cord,
Okay, excellent. Okay, so tumor volume is high. So don't use the correct word. Tumor volume is high,
Yes.
crossing over to the opposite cord, and
Extensive paraglottic involvement.
okay, okay, I'll agree to that. Yeah.
And early cartilage erosion, sir.
Yes, inner perichondrium, but that will upstage your tumor. Okay, then what else?
Mm,
Do you want to think about vertical extension? Do you want to think about neck nodes? Do you want to think about anything else?
yes, sir. If neck nodes are involved and if there is subglottic or supraglottic extension, also radiation is better, sir.
Okay, very good. So you have have to know the so what is the ideal patient for TLM?
Sir, preferably a T1 tumor lateralized to single cord, probably a mid-cord lesion with limited paraglottic spread, sir. Paraglottic or it is preferably horizontal growth with limited vertical extension, sir.
Okay, so good exposure, mid-cord lesion, no extensions, no subglottic spread, cords are mobile. You would prefer a TLM.
Yes, sir.
So, what is the critical factor that you'll prefer TLM in a patient? Something about the patient, not the disease.
Mm. So if the patient is not willing for
That is different. Younger patients benefit more from TLM compared to radiation
yes, sir.
because you have radiation induced tumors and you want to preserve radiation for a future use and whatever. So, what is the laser that you'll use for TLM?
Carbon dioxide laser, sir.
Why?
It is more precise compared to other.
KTP also can be more precise. Why carbon dioxide? What is the depth of penetration of carbon dioxide compared to KTP?
Uh, 2 mm, sir.
No. Okay, that is a different discussion. So carbon dioxide has less thermal penetration.
Yes, sir.
And it causes less thermal damage to the cords.
Okay.
Because the new pseudocord should not have damage and they should be pseudo vibrations and things like that.
Okay.
Okay, so this patient, I'm telling you, you have taken for TLM.
Yes, sir.
Let's imagine that this didn't go to the anterior commissure because anterior commissure margins are slightly difficult and you have to go to the contralateral cord to get. So, what are the margins in TLM?
1 to 2 millimeters, sir.
Okay, I am telling you, one patient came with uh, um, 1 millimeter margin in the super. So, how do you classify margins in TLM?
I'm not sure, sir.
No, there's superficial and deep margin.
Yes, sir.
So, what is your assessment of these margins? Is superficial the same as deep margin? Is superficial less kind than deep margin? How do you assess that?
Deep margins. I'm not sure, sir.
So, if you have a superficial margin that is close or positive, you can follow up the patient.
Yes, sir.
Okay, that is the data from Italy.
Okay, sir.
If you have a deep margin positive, what will you do?
We have to do revision, sir.
Okay, what is the difference in prognosis?
It's a deep margin.
So, if you have a deep margin positive, will you re-resect or will you send the patient for RT? Your personal thing.
Yes, sir. So depending on the type of cardectomy, sir. If we have already done a type 3 cardectomy, then it would be difficult to get margins. So
very good, excellent. So you have to assess the initial extent of cardectomy. I agree with you 100%. Very good. Yeah.
And if it is a type 3 cardectomy, then getting a vertical negative margin is very difficult. So
yes,
I would like to, but
no. Before that, how will you classify this patient? Jiva, answering is all about talking. How will you? So, if you have done an extensive cardectomy
yes, sir.
with deep margins,
Yes, sir.
what is this patient?
Mm, we,
What risk is this patient?
patient will have extensive raw area exposure.
No. What is this high risk patient?
Yes, sir. Yes, sir. High risk patient.
So, what is the treatment of a high risk patient following TLM?
Radiation therapy.
Excellent. This is how you should answer.
Okay, sir. Okay.
I have done extensive cardectomy. Type 3 is very extensive.
Yes, sir.
But still the deep margins came positive.
Yes, sir.
This is an infiltrative tumor and a high risk tumor.
Yes.
I would want to send the patient to adjuvant RT.
Yes, sir.
Okay, your superficial margins came close. Will you revise or you will wait?
We can wait, sir.
Why you want to wait?
So in the immediate post-operative period, we cannot give radiotherapy, sir.
No, that's not the answer. If you have a superficial closed margin, does it affect recurrence or laryngectomy free survival?
I am not very sure, sir, but
no. Answer. Say yes or no.
No, sir.
Think logically. Think logically. Why am I asking you this question?
It won't probably.
Very good. So superficial closed margins don't affect the laryngectomy free survival, while the deep margins affect laryngectomy free survival. Okay?
Okay, sir.
Okay. So what are your rationale for giving radiation to a T1 larynx? What is the radiation schedule and what are the side effects?
We'll irradiate the tumor with 60 to 66 gray.
No. Oi, for T1 larynx. What is the Christie's protocol? What is the in Tangam? Do you give 60 gray for a T1 larynx? Seriously, for a T1 larynx, you give 60 gray.
63 to 66 gray.
Oh my God! No. That's not acceptable. For a T1 larynx, lateralized tumor with cord mobility, everything in place, how much do you give?
I'm not sure, sir.
Do you give single cord irradiation or both cord irradiation? Do you do hypofractionated Christie regimen? What do you do for a T1 larynx? I mean, the answer might be different for anterior commissure involvement, but we are talking about lateralized vocal cord lesion. What do you give? Is it standard fractionation? Is it altered fractionation? What is the dose? How many days? What do you give?
Unilateral cord irradiation.
Very good. Very good.
And dosage 40 gray, sir. I'm not very sure.
40 gray is not even enough for animals. We have to give something more. It's not even enough for dog and cat. What do you give? What is Christie's regimen, which is followed all over the world now? 41 hypofractionated.
I'll read, sir.
54. Okay, over 20 fractions. That's what we give for T1 lateralized vocal cord lesions. Okay. So what are the complications of giving highly selective hypofractionated radiation for T1 larynx?
Ipsilateral restricted mobility of cord, sir.
No, it never happens. Okay. Tell me, how many patients have you seen with cord fixity after radiation in your training time?
We usually only advanced larynx patients.
Yeah, I'm asking you for T1.
Yes, sir. No, sir.
It doesn't happen.
Yes, sir.
It doesn't happen. Tell me again. Okay. What we have discussed now is T1 has two options. I forgot to mention the other option is that if NBI shows extensive field cancerization, they are better for radiation.
Okay, sir.
If you can't get adequate margins, they are better for radiation.
Okay, sir.
And if you don't have exposure, they are better for radiation. Everything else is better on the TLM side.
Yes, sir.
Okay. This T1 patient came back to you after 2 years with a recurrence.
Okay, sir.
At the same site.
Okay, sir.
Previously radiated.
Okay, sir.
And now cord is fixed.
Okay, sir.
What would you do?
I would like to do PET CT of the patient to
Yes.
To assess the local, regional, and distant extent of.
So, do you think PET CT will give you enough resolution for the larynx?
Sir, I would like to complement it with HRCT, sir, of the when we
So
are.
you want to combine PET with the cross-sectional imaging. Diva, this is how you answer.
Okay,
When
sir.
patient comes back with recurrence after prior radiation, I want cross-sectional and systemic evaluation. Correct?
Yes, sir.
So cross-sectional is with high resolution contrast CT and systemic with PET CT scan. Very good. Okay, then what will you do? I gave you the scenario. Same right cord patient came back to you after 3 years with cord fixity and a new growth. What are the reasons for cord fixity in a patient who has been previously treated for laryngeal carcinoma?
So one is a recurrence of the growth with involvement of retinoid complex.
Okay, so go, stop. First, like you said, cricoarytenoid unit is involved. Cricoarytenoid unit, CAU is involved. Okay, very good. Next. So the meaning is that the tumor has progressed posteriorly, or the recurrence has gone posteriorly towards the cricoarytenoid unit. Very good. Okay. Second.
So if in case of recurrent laryngeal palsy, sir.
That is very rare because it has to go out of the larynx into tracheoesophageal groove. It's very difficult to say. Second is paraglottic space involvement.
Yes, sir.
Okay. What will you do in this patient? Right vocal cord fix, right cord growth. What will be your decision process?
So after restaging the patient.
Excellent. Very good answer. After restaging, that is the most important thing, because what is second primary and what is recurrence?
So within 2 years at the same site, it is recurrence, sir.
Okay, so I said 3 years. So, or let me say 5 years. So you're saying it's a second primary tumor.
Yes, sir.
And restaging is very important for second primary tumors. Excellent answer. Then what will you do?
If there is no gross cartilage invasion or extrathereal disease.
I didn't ask you for all that. That is the next question. What will you do is what I asked.
I would do a direct laryngoscopy and rebiopsy the lesion, sir.
Okay, very good.
And based on the imaging findings, I would like to proceed, sir.
Okay, so I am restaging this as T3N0.
Yes, sir.
What would you do?
Patient has already received patient has already received radiotherapy, sir. So I would like to do conservative laryngectomy, sir. Near total laryngectomy or supracricoid laryngectomy, sir.
Okay, near total laryngectomy is like total laryngectomy with the muscular mucosal shunt for voice. Yes, tell me the prerequisites for a supracricoid laryngectomy.
The cricoretinoid unit has to be free, sir.
One cricoretinoid unit has to be free. Okay, yeah, at least one. Yeah, okay. It will become an extended supracricoid. Okay, very good.
And
excellent answer.
Sir?
Yeah, what else should be free?
There should not be extensive cartilage erosion, sir. No.
There should be subglottic extension, not extensive cartilage. Okay. So that is the second point. Then where else should it not extend?
Into.
If intraethnoid space is involved, you'll do supracricoid?
No, sir.
If the contralateral 2/3 vocal cord is involved, will you do supracricoid?
No, sir.
If base of tongue is involved, will you do supracricoid?
No, sir.
And if the patient's lung performance is bad, will you do supracricoid?
No, sir.
So salvage conservative laryngectomy, you should know the indications.
Okay, sir.
You understand, no?
Yes, sir.
If patient came to you with a second primary or radiation failure, a supracricoid is possible if it passes all these requirements. You understand?
Yes, sir.
If extensive base of tongue is involved, how will we do supracricoid?
No, sir.
We can't. If intraethnoid is involved, how will we do supracricoid?
Yes, sir.
If anterior subglottic extension is there, how will we do supracricoid?
Yes, sir.
If both vocal cords are fixed, how will we do supracricoid?
We cannot do, sir.
Then tell me now the indications for near total laryngectomy. Jiva, read supracricoid and extended supracricoid also.
Yes, sir.
Because they are two conservative procedures that we can do provided all the prerequisites are met.
Yes, sir.
So your exam question will not be on how you manage T1. It will be on how you manage T1 with investigations and clinical evaluation, and how will you manage the recurrences of T1.
Yes, sir. Yes, sir.
You understand? No. What is there in T1? You can say TLM or radiotherapy. Both your answers will be correct, but the question will be how will you manage recurrence of T1, correct?
Yes, sir.
Don't you think that is the more important question?
Yes, sir.
Management of T3, T4 larynx, not T4, T3 larynx and selected T4 are treated with chemoradiation. Yes, the answer is very simple. Total laryngectomy if there is recurrence or residual or second primary, correct? There is no discussion there.
Yes, sir.
But in T1 you will be caught where how will you manage recurrences?
Yes, sir.
Agree? No, you understand? You agree with me, right?
Yes, sir.
Okay. What is the requisites for near total laryngectomy?
Sir, the tumor should be lateralized, and at least one cricoid unit has to be free.
Yes.
Along with preserved RLN function.
Yes.
And contralateral vocal cord at least 2/3 has to be free.
Yes.
And the retroretinoid unit and interretinoid unit has to be free.
Okay.
As you said, there should be no base of tongue involvement and no subglottic extensions.
Excellent. So how do you classify subglottic extension anteriorly and posteriorly?
Sir, I'll read, sir.
Which is 5 mm, which is 10 mm?
Sir, anterior is 5 mm, sir.
You read. Why? Okay, you read. What are the reasons for the differences based on the epithelium that you have? There's a different epithelium in the larynx, and there's a different epithelium in the trachea and subglottis. Okay, so Jiva, your history was great. Your clinical examination findings were great. Your further evaluation, both clinically and radiologically, also was great.
Okay, sir.
Your decision making between T1 radiation, some examiners might say when you have anterior commissure involvement, you need radiation. I accept with all that.
Yes, sir.
But when you are asked to counter, you have to say that TLM has better laryngeal preservation rates than radiation.
Yes, sir.
And then the question will be how will you manage a recurrence or second primary?
Yes, sir.
So you have to say, I want certain prerequisites that have been followed.
Yes, sir.
Then I can think of all your answers of supraprocare are correct and your total are correct.
Yes, sir.
If it is not possible, then you have to do a total laryngectomy.
Yes, sir.
Now, after a total laryngectomy, how will you voice rehabilitate the patient?
Either tracheoesophageal prosthesis.
No.
We have
I told you, answer that dialogue.
Yes, sir. Yes, sir.
I told you, you have to answer. Everything is about classifying and speaking, Jiva.
Yes, sir.
நான் இந்த வயசுல வந்து இதெல்லாம் நான் படிச்சுட்டு தான் வந்தேன் 15-20 வருஷமாட்டு I have tried to. So how will you? So you have to how will you classify post laryngectomy speech?
Natural speech and.
No, correct. Natural speech is alaryngeal speech.
Yes, sir.
Alaryngeal speech, correct?
Yes, sir.
Alaryngeal. Second is prosthesis, prosthetic speech.
Yes, sir.
And third is electronic devices.
Yes, sir.
What is the alaryngeal speech that you want to do?
Esophageal speech, sir.
Okay. What are the prerequisites for esophageal speech?
It's very difficult to train the patient in.
No. Assume prerequisites of alaryngeal speech.
Sir,
do you have Cummings with you? Cummings otolaryngology, head neck surgery textbook with you?
Yes, sir. We have in our library.
So there's a chapter for which edition do you have? The brown, the white and black edition. Do you have that? Adana PG 20 years back.
Blue and.
Must be the new one. There's a chapter there. Okay, so you want to teach the patient esophageal speech. Yes, that sir. Requires motivation training. What is the problem with esophageal speech?
Difficult to train the patients.
Yeah.
And it can be only simple words and syllables can be spoken.
Sorry. Correct. What did you say?
Complex sentences cannot be made, sir.
So the voice output in terms of number of words
yes,
is
sir.
limited, correct?
Yes, sir.
Why? Because the gastric reserve of air is small.
Yes, sir.
Okay, so one is esophageal speech. Next one?
Next one is the tracheoesophageal prosthesis, sir.
That is prosthetic driven speech.
Yes, sir.
So that is what is the advantage of tracheoesophageal speech?
It gives a natural.
There is no natural voice, but between stomach and lung, which has got more volume?
Lungs.
So it's a lung-driven speech.
Yes, sir.
So your sentences are longer, your word output is longer.
Yes, sir.
But what are the problems with tracheoesophageal speech or tracheoesophageal puncture?
Sir, any infection, dislodgement, and.
Yeah, so you have tracheoesophageal prosthesis related problems.
Yes, sir.
That can be leak, that can be high pressure, that can be so many things. Okay, what is the third speech?
Third one is the electrolarynx.
Electrolarynx. Yes, what sir. Are the advantages and disadvantages of electrolarynx?
One is it is a robotic speech, sir.
Yes.
Patient need external device.
Yes.
The time.
Yes.
Use and
it doesn't require any training.
Yes, sir. It
doesn't require any prosthesis. But like you said, it's a mechanical voice.
Yes, sir.
And if the neck is fibrous, it's difficult to transmit the vibrations
yes,
from
sir.
the electrolarynx into the mouth.
Yes, sir.
Okay. Will you do primary tracheoesophageal puncture or secondary esophageal puncture, TE puncture?
And now recent studies suggest that in both salvage setting also we can give primary TEP.
Excellent. What TEP will you use? How do you decide the TEP?
I don't know, sir.
No, TEP has a width and has a length.
Yes, sir.
Correct?
Yes, sir.
So what would you use? Have you seen TEP being placed?
Yes, sir.
Okay, how do you decide?
I don't know, sir.
So first the length of the patty wall, no?
Yes, sir.
So how do you decide that? And second is the width of the prosthesis, right?
Yes, sir.
It can be 20 French, 22 French, whatever.
Okay, sir.
So read that chapter in Cummings. It's a very good chapter.
Yes, sir.
Okay. Okay. Tell me the steps of total laryngectomy.
So by making a Glexorance and incision,
Okay.
raising the flaps, and
Yes.
Previously we have to, by doing a direct laryngoscopy, we have to mark the extent of the disease.
Oh, that's all okay. I'm just asking you the steps of total laryngectomy.
Yes, sir. After raising the flaps and making adequate exposure.
Yeah.
One side we have to tie the superior thyroid artery. I mean, along with.
No, what is the first step? I'll tell you clearly. What is the first step?
Yes, sir. Stoma marking, sir.
No. First is to expose the paracarotid tunnel.
Yes, sir. Yes, sir.
What are the contents of the paracarotid tunnel?
Recurrent laryngeal nerve and.
The recurrent laryngeal nerve is low down. What are the? Okay, you open the neck. You are going medial to carotid. What are the structures that you'll see?
Superior thyroid, inferior thyroid.
No. Before that, what muscle will you see?
Strap muscles, sir.
No, not strap muscles. Before that, what will you see?
Sternocleidomastoid.
No, before that, what will you see? Paracarotid is medial to carotid. How will you see sternocleidomastoid there?
No, sir.
What muscle comes from deep neck going up to hyoid?
Omohead.
So first step is neck incision.
Okay, sir.
Second is raising the flaps.
Yes, sir.
Third is identifying the paracarotid tunnel.
Okay, sir.
In the paracarotid tunnel, you have two structures.
Yes, sir.
One is the omohyoid.
Yes, sir.
What is the next structure? Something which goes to thyroid from IJV.
Middle thyroid veins.
So you cut the omohyoid and you ligate the middle thyroid vein if it is present.
Yes, sir.
Okay, then what will you do? You have to skeletonize the thyroid cartilage, correct?
Yes, sir.
How do you do that?
Cutting the strap.
Excellent. Cutting the strap muscles. So you have to cut the strap muscles as close to their origins as possible.
Yes, sir.
After you cut the strap muscles and reflect, what will you see? What is below the strap muscle?
Thyroid gland.
Correct. Excellent. So in which cases will you preserve the thyroid gland? In which cases will you take the thyroid gland with your specimen?
Usually we will do ipsilateral hemithyroidectomy on the side of lesion, sir.
Okay, then?
If there is anterior cartilage erosion, we need to do.
Okay, correct. Then? What about nodes? If you see paratracheal nodes or something, will you preserve that lobe?
If there are paratracheal nodes, we need to remove that.
Okay, so very good. 3 indications. Extralaryngeal extension, piriform sinus lesions that are going out, and then if you have nodes on that ipsilateral paratracheal region. Excellent. Very good answers. Okay. Then what will you do?
Devascularization.
Correct. Expand on it, Jiva. She said correct.
Yes, sir.
How do you skeletonize the larynx? My simple question. You have cleared the paracarotid tunnel, you have ligated the middle thyroid vein, you have cut the strap muscles, and you have taken the ipsilateral thyroid along with your specimens. Then how will you dislocate the larynx? What are the remaining attachments of the larynx?
So with the
superior, what is the attachment? Inferior, what is the attachment?
Superiorly hyoid bone, sir. And
not hyoid bone, above the hyoid bone, no?
Yes, sir.
Above the hyoid bone.
Above the hyoid bone.
Inferiorly?
Inferiorly continuous trachea and.
Okay, very good. Above hyoid bone, inferiorly trachea. Posteriorly, what you want to do?
Posteriorly, we have.
I'm asking posteriorly, superiorly, and inferiorly. What will you do superiorly?
We have to cut the suprahyoid attachments, sir.
Excellent. Very good answer. Then what else do you have to cut?
After carefully preserving the lingual artery. And
okay, ma. What do you cut? Do you want to cut the pharynx along with your specimen, or you want to preserve the pharynx?
We need to preserve the pharynx.
Okay. Inferiorly, what will you do?
Inferiorly, we need to isolate the trachea from.
Okay, excellent. Sorry, I interrupted you. So, inferiorly, you isolate the trachea from what?
Yes.
Very good. Okay, so you have done the inferior.
Yes, sir.
You have done the superior.
Yes, sir.
You have preserved the lingual artery, hypoglossal, everything. You have cut the stylohyoid ligament. You have cut the mylohyoid, everything. How do you decide the pharyngeal cuts?
Yes, sir. We have to preserve as much mucosa as possible.
Correct. Sir. Correct.
We have to strip the mucosa from the inner.
No stripping. Where do you cut?
So you have to make a pyriform sinus entry, sir.
No, that is only if the pyriform sinus of the opposite side is involved. Normally, what do you do? You have to cut along the which fold? We have to cut across the aryepiglottic fold, correct?
Okay, sir. Yes, sir.
When you make the pharyngotomy opening at the base of tongue, where do you cut? You cut along the pharyngoepiglottic fold, correct?
Yes, sir.
And then where do you communicate it? From both sides.
Yes, sir.
Where do you communicate it?
Into.
Which is above the esophagus?
Postcricoid area.
Excellent. So let me tell you. Skin, neck flap,
yes, sir.
paracarotid tunnel,
yes, sir.
omohyoid, middle thyroid vein,
yes, sir.
suprahyoid release,
yes, sir.
and sublaryngeal release in the trachea.
Yes, sir.
Cut along the aryepiglottic fold till you communicate with the postcricoid.
Yes, sir.
What are the types of pharyngeal closure?
The primary closure and.
No, tell me the techniques. You're all general surgeons. You should know the different types of bowel closures. What are the different types of bowel closures?
And Limbert and.
There's a Connell's. There's so
Limbert,
many different. So, what do you do for the pharynx? What is the ideal closure for the pharynx?
It's a T-shaped closure, vertical closure.
Oh, no. I will kill you with that. Tell me the three types of closures. Connell is not T-shaped. Connell is a different thing.
Yes,
T-shaped is a type of physical closure.
Yes,
it doesn't say if it's extramucosal, intramucosal, whether it's running or interrupted or locking. It doesn't say any of that.
Yes, sir.
Okay, I'll go with your answer. Why is T-shape better?
The shape of the remnant pharyngeal mucosa will be better.
No, why is T-shape better? What is pseudovalvular?
Don't know, sir.
So, if you do a linear closure, straight closure, patients have a symptom, have a sign called pseudovalvular that causes dysphagia. T-shaped closure avoids pseudovalvular. So, you have to know that.
Yes, sir.
And then how will you do a cricopharyngeal myotomy?
Vertical superficial cuts.
Is it vertical or lateral?
Lateral, but along the axis, sir.
No, lateral is better.
Okay, sir.
Lateral cricopharyngeal myotomy is better than central thing. Okay, when will you put an onlay muscle for pharyngeal closure?
So when we have already closed it primarily, and we want to reinforce it, we'll put onlay closure.
So I will restate your statement that in patients who are having salvage laryngectomy,
Yes,
an onlay pec major is better for leak rates. So the leak rate is the same, but the duration of leak is less. There are a lot of papers, a lot of trials going on. So if you're doing a salvage laryngectomy, you want to close the pharyngeal closure with a onlay pec major.
Yes, sir.
Yeah?
Yes, sir.
Jiva, you are happy?
Yes, sir. Yes, sir.
Yeah, let's go to the next case.
Yes, sir. Thank you, sir.
Does anybody else in the meeting have any questions? Please speak out.
Sir, me, yes, sir.
Kanna,
Sir,
speak out, Kanna. I can't hear you. Sorry.
Sir, in case of evaluation,
no,
when they
introduce
ask,
yourself first.
Sir,
and then...
my name is Ishfaq, sir, from Hyderabad, sir.
Please tell me mine.
Sorry. Sir,
why are you saying sorry? What sorry for? Just tell what. I just want to know who I'm speaking to, nothing else.
Sir, in case of evaluation, when they tell us how to evaluate the case, shall we do directly that we will go for direct laryngoscopy, or we should say we will proceed with indirect first or some flexible like that when during presentation?
Okay, very good point. If you can the problem with flexible is that we can't evaluate the lateral recesses. Learn this word. We can't evaluate the lateral recesses because the flexible doesn't show that. Flexible, as per all the guidelines and all the things, is not part of laryngeal cancer evaluation. Okay, so when the patient comes to the OPD, you do a scan and then you do a diagnostic direct laryngoscopy. Kanna, are you there?
Yes, sir. He's hearing, sir.
Yes, sir. Yes, sir.
Yeah. So when you see a larynx patient,
but direct will require anesthesia, sir.
Doesn't matter. You are making your decision based on that, no?
Okay, sir. Okay, sir.
No. How else can you assess the ventricle? How else can you evaluate the petiole? And how else can you evaluate subglottic? Subglottic maybe with flexible scope you can see, but direct laryngoscopy is the gold standard. Nobody will blame you in your exam for that.
Okay, sir.
You understand?
Yes.
It is a combination of radiology and clinical. Because our decision making and staging will change on all of that. I can quote 10 papers of flexible laryngoscopy for evaluating laryngeal carcinomas, which have all been negative compared to direct laryngoscopy and imaging. So it's not true.
Okay, sir.
It's not true. Kanna, is it okay? Did I make the point? Did I make the point?
Yes.
So in your exam, you say, sir, it's a combination of direct laryngoscopy and radiology. That's all.
Okay, sir. Okay,
in exam, when you go, you should never give all your answers at the same time. Learn it from me.
Yes, sir.
You should never give all your answers at the same time. You should provoke questions in the area that you know. Lot of mistakes that people do in DNB and MCH is that they tell everything they know. Then the next question will be something that the examiner also does not know the answer. Examiners can ask you anything, no?
Yes,
it's not necessary that they know the answer. They can just ask anything for the fun of it.
Yes, sir.
Yeah?
Yes, sir.
It's all about tempering your answers and engaging a dialogue. It's like you speaking. It's like you're giving a conversation. Never cut off your legs. Never burn bridges. You give little bit, they'll ask little bit. You give little bit more, they'll ask little bit. You give little bit more. But you have to be sure of what the final answer is.
Okay, sir.
See, I'm not saying it because you guys don't know stuff. You guys know more than me. But the problem is you guys will tell everything that the examiner wants, and then the examiner, just to feel superior, will ask something which nobody knows the answer.
Yes, sir.
Yeah. You all agree with me, no? Questions can be random, totally nonsensical with no answer, correct?
Yes, sir.
If I ask you a simple question, why is DL-scopy better than radiology? Where is the answer? Where is the answer? I also don't know the answer. Where is the answer? And I've been doing it for decades. Where is the answer?
Yes, sir.
But that will go as a negative mark against you. No, I asked question and he didn't know. That will go against you, right?
Yes, sir.
You guys are all very smart, much smarter than any examiner, anybody who's asking you questions. But you have to know how to give those answers.
Yes, sir.
That's all that matters. This is not a question of your intelligence.
Yes, sir.
This is a question of how you speak. That's
Okay.
all.
Okay.
Yeah?
Okay, sir.
Yeah?
Yes, sir.
Thank you, sir. Thank you, sir.
Let's go to the next case.
Okay, sir.
Who's presenting this?
Sunita, sir.
From where?
Sir,
Tangam Hospital only,
Hospital.
Ah, Sumita, please.
My patient is a 33-year-old lady who is a daily wager from Namakkal, presented with the chief complaints of swelling in the anterior aspect of the neck for past 6 months. Patient was apparently well 6 months back, following which she noted a swelling in the anterior part of the neck, which was insidious in onset and started with 2 centimeter size swelling and gradually progressive to attain the present size. And she had no history of pain over the swelling, no history of change in voice, difficulty in swallowing, breathing difficulty, no history of any fever or trauma, no history suggestive of hypo or hyperthyroidism, and no history of any other swellings in the neck, no history of cough, hemoptysis, or bone pain.
No change in voice, no?
Yes, sir, no history of change in voice.
Yeah, okay.
Patient did not give any previous comorbid illness, no medical or surgical history in the past, and also no history of childhood irradiation, and also no history of any allergic to medication. Patient is a mixed diet consumer with normal bowel and bladder habit with normal sleep pattern. She attained menarche at 14 years of age. She is a para 2 live 2 lady with regular menstrual cycle 3/30 days, with no other menstrual disturbances and no family history of thyroid or any other malignancy running in the family, and no significant treatment history in the past.
Very good. Yeah. So summarize your history. It's just a swelling in the neck with no associated symptoms.
Okay, sir.
Yeah, okay. Findings. So when you get a case of swelling in the neck, obviously you have to give if there's a swelling in the neck, how will you DD this in the history? How do you classify neck swelling?
The neck swelling can be divided into midline swelling or
Excellent answer. Excellent answer. So midline and lateral swelling.
lateral swelling.
Then how else can you further classify this?
Then in midline swelling.
No. How do you further classify this? I'm not asking you particularly about this midline swelling. How do you classify midline swelling?
Thyroid swellings or?
No. How do you classify? How do you classify it? So there's congenital and acquired, correct?
Oh, yes.
There's congenital and acquired. Do you think this is a congenital swelling?
No, sir.
This is an acquired swelling. So please, it's all basic, Amma, just to ask questions. I know you're talking about a thyroid swelling. I have nothing against that. Congenital and acquired. So this is an acquired midline neck swelling which has been there for a couple of months. Okay, go to your findings.
Sir, local examination on inspection, there was a 3 into 3 centimeter swelling in the region of the left lobe of thyroid, extending from anterior border of left sternocleidomastoid up to midline and 2 centimeter below the thyroid notch and 2 centimeter above the suprasternal notch. And skin over the swelling was normal with no any other swelling in the neck. On palpation, there was a 3 into 3 centimeter swelling palpated in the left lobe of the thyroid, which was non-tender, not warm, with well-defined margins, smooth surface, firm in consistency, and extending 3 centimeter below the hyoid bone, 2 centimeter above the suprasternal notch, from anterior border of the left sternocleidomastoid to midline. And the skin was normal and pinchable, and the swelling moves with deglutition. Trachea was in midline, and carotid was felt normally, not displaced, and no other palpable cervical lymphadenopathy.
Very good. So, what's your diagnosis?
Summary, should I tell?
No, just tell me your diagnosis.
Sir, my patient, 33-year-old lady, presented with an solitary thyroid nodule